Good afternoon, everybody, and welcome to session 4 of the Social Isolation and Loneliness series. The Wellbeing Tree, or Teaching Resilience to Empower Elders Learning and Action Network, is brought to you by Altarum with grant funding from the Michigan Health Endowment Fund. Altarum is a nonprofit headquartered in Ann Arbor, Michigan, and been in existence for nearly 80 years. We help federal and state health agencies and foundations improve health equity and outcomes through better systems of care for lower income children to nursing home eligible older adults. Our mission is to help those whose health is negatively impacted by social determinants. My name is Colleen Quintel, and I'll be moderating today's session along with Christy and our teammates Ann, Allison, Bethany, and Holly. The WellbeingTREE collaborative learning platform has provided Michigan nursing homes with tailored learning to better recognize and implement evidence-based strategies to create healthier homes in Michigan. This Learning in Action network focused on improving conditions of social isolation, loneliness, bereavement, and grief. Thank you for joining us today. During the first 6 sessions of the WellbeingTREE Land, Dr. Tony Miles spoke to us about grief and bereavement. The Eden Alternative presented the first 3 sessions of the Social Isolation Loneliness series. Today, we have the immense privilege to share with you Dr. Maureen Mikas, who will cover the last 2 sessions of the Social Isolation and Loneliness series. Dr. Mikas is a gerontologist, a professor at Western Michigan University, and a recognized speaker on loneliness in older adults. During her vast career, she has conducted a vast amount of research on social isolation for individuals late in later life, including the use of technology. Her lifelong passion relates to issues about older persons. She is committed to finding ways in which society can create an exclusive world for those with Alzheimer's disease and establish effective and enduring support for marginalized elders. Please join me in welcoming Dr. Mikas.
Thank you so much, Colleen. I appreciate your support and that very kind introduction. So before we get started today with objectives and a whole host of PowerPoints on this topic, I'd like to just share with you a little bit from a personal standpoint about why this topic is so enormously important to me and where it even came from in the way of how did I become interested in loneliness. Colleen is correct. I am a gerontologist. I have a PhD in gerontology. It's been part of my life, my entire adult life. But I want to say, as a young child, I had very distinct experiences that I recall to this day. And visiting older people, it was part of our family culture that you spent time with older people, not just grandparents, but older neighbors, taking cookies over to this person, going over and doing an errand for this person. It was just part of the way that I was raised as a child in a small town in the Midwest. Some of you may have shared those values. And I remember, for example, visiting a woman, an older woman. She was probably in her late 80s, named Rosa Miesing. She was this lovely older German woman who lived by herself. And my mom would quite often send me over there to take something to Mrs. Miesing. And I couldn't have been more than 8 or 9 years old. And I remember going to visit her and really enjoying her. Part of my development as a gerontologist was learning to be with older people and just enjoying them really as friends. She would braid my hair and she would sing German songs to me. And I remember really enjoying that time with her. But I also very distinctly remember leaving her little small 2-bedroom home down the street from us and feeling she's alone. And she just seemed lonely to me and really brightened up when I would come to visit her. So I had those early childhood experiences, not just with Mrs. Miesing, but with others in my life that I saw. They may have been widowed, their children might have moved farther away. And it was a very prominent part of my understanding of aging, that not for all older people, but some older people are very much alone and as part of that feeling lonely. I want to fast forward to my professional life. I started working at Michigan State after I finished my PhD, and I was in the Department of Psychiatry for 10 years. One of my colleagues in the Department of Psychiatry was a geriatric psychiatrist, a specialized training in working with older adults, geriatricians, geriatric psychiatrists, and her specialty was depression. That was sort of what she was. Some people would specialize in eating disorders. She specialized in depression. And we would have many conversations about the patients she treated. And we wrote a couple papers together. We did some research together. And when I started thinking and reading and understanding that there was a body of literature emerging related to loneliness specifically, I remember asking this physician, I said, do you see loneliness in the patients that you see? Now, mind you, remember, she's seeing many, many people being treated for depression, late life depression. And she said, oh, there are plenty of my patients who are lonely, my older patients who are lonely. And I said, okay, to myself, well, that makes sense. So I said to her, well, do you assess the loneliness? Do you actually take time to assess that, to evaluate loneliness? And her answer, which I remember years later, her answer was a very unequivocal, no, I don't. And I was really taken back by that. And I thought, I don't understand. Why wouldn't you, if you've identified a problem, a condition in a patient, especially a mental health condition? I asked her, I said, why don't you assess these patients? And she's turned to me and she said, if I assess them as loneliness, I wouldn't know what to do with it. So that has always been a comment that's stuck in my brain, that we have shied away from loneliness as a condition needing attention and needing treatment, because I think in the past we thought it's really sad, it's really unfortunate, but there's nothing I can do about it. As a healthcare professional, as a social service professional, what can I do about it? It's unfortunate, but nothing I can do about it. So fast forward, since that time, loneliness has taken a much more center stage, and there are steps that we can take. There are interventions. We have science. We have research backing up ways that we can address loneliness, which will be the topic of the next session. So that's the backdrop of how I became interested, and I'm acutely aware of social connections that people have in their life, and I feel strongly that all of us need to be paying attention to our social health as well as our emotional, physical, and mental health. At this point, I'd like to turn to the learning objectives and share with you what I hope that we are able to accomplish today in this session, this short time we have together. The objectives for this talk today are relatively straightforward. The first, I know that some of you have participated in other sessions, and so perhaps some of this will be a review for you. For others of you, this is perhaps new information to just think about what is loneliness and how does that differ? How does it relate to social isolation? The second objective is to help you understand perhaps why I feel so strongly about this, the negative toll that this takes on our lives, both physically and mentally. And then the third item on this list has to do with understanding what are the factors, what are the characteristics of the individuals that you serve in the long-term care facilities across the state. What are those factors that really contribute or put someone at a higher risk for loneliness? Those are 3 objectives that I have today, and I hope by the end of that you will all be struck with the fact that this is important and that we should all really pay attention and care enough to make a difference in the lives of the people that we serve. So I'm going to start with a word cloud, and it's a fairly simple question, but before I launch into more definitions, I'd like to just have you think about, when you hear the word loneliness, what does that conjure up for you? There is all kinds of emotions that we could tie to loneliness. What are the ones that really resonate with you? I'm hearing some of these come in. So when you look at the list of those of you who've responded, the 9 responses, some more coming in, melancholy, just some of these to just read back. Depression obviously is something that is very strong. A lot of you cited depression, fear, despondency, despair, anger, melancholy, isolated, ones that I might have missed. Empty, that's a really interesting one. Emptiness, feeling empty, feeling uncared for. If you think about those emotions or those outcomes, if you will, from loneliness, these are all enormously serious. They pose very, very serious risks for our health and well-being. And I'm going to talk about that some more later, but I appreciate you taking time to do this. And the one, of course, that is the strongest response here is sadness. These are, again, conditions that all of us care about and need to be very mindful. What is going on? Where is this coming from? What is the impact that loneliness is having in the lives of the nursing home residents that you serve? I'm about to show you a very short video. I don't think it lasts more than 2 minutes, but I think it's enormously interesting. This is a video that was filmed in England, so there's a little bit of a different accent. I want to tell you a little bit of background on what's happening here. In England, which is probably one of the countries that rises to the top as far as really addressing loneliness, they have hired a minister of social, I can't remember the exact title, but minister of social connections of something of that sort. So a minister level in England is the same as a cabinet position. It's like the Secretary of Homeland Security. They're called ministers, most of you, or not all of you know that. So they've actually taken this on so seriously. They said, we see this as a problem and we're going to try to find ways to tackle it. And I'm going to talk more about that campaign at the end today. It's a fantastic resource available in England, and I'll talk about that at the end. But right now, to get into this film, this young man is part of a social experiment, and it'll probably remind you of COVID, right? Because he's asked to stay in his apartment or flat, as he refers to it, for an entire week without seeing anybody. No FaceTime, no Zoom. Everything is done just by himself in this little apartment for an entire week. And so he's going to talk about what that experience was like, what that felt like, what kind of emotions did that conjure up for him. And then at the very end, he's going to go nearby to a nearby neighbor, next door neighbor perhaps, an older man, and share that information with him. It's just a few minutes long. We'll take a look at what this looks like.
So they've taken my phone off me and my tablet and my smartwatch. It's still early doors, but so far it's been remarkably quiet. I just fell asleep on the sofa in front of the television. When I woke up, I had that instinctive reaction to check my phone, which is just a normal thing to do, and obviously it wasn't there. It's been a bit lonely, but it's not been unbearable. Being used to living with lots of people as well, it's a big difference. Usually when I wake up, I check like the news apps on my phone to see what's going on in the world, that sort of thing. I think it's not so much about the technology, I've realised, but it's about the feeling of having a connection. I can hear the people in the neighbouring flats heading out in the hallway, off to do something a bit more exciting, I imagine. I'm quite jealous of that. I'm starting to find it quite difficult, to be honest. I can't sleep at all. It's almost like I'm not mentally prepared for bed because there's not been a beginning, middle and end. It's just been a constant nothingness. Morning. So on the bright side, today's the last day. I'm just counting down the hours now. And I've just kind of gone into robot mode. If you start overthinking things, you start thinking about how lonely you are. I'm supposed to do these video diaries, but I don't know what to say. Call your bum, I suppose.
Are you Joe?
I am, yes, nice to meet you.
Hello, Joe.
How are you doing?
I'm very well, thank you. Come in.
Thank you very much.
How did you survive?
It's a good question. It was certainly certainly very trying at times, I think. A real sense of being left out and being alone and not being part of it and being very cut off.
It's not something you think about, is it? Until it actually happens to you. And then suddenly you become aware of it and realise the significance of what goes on in the world and how many people are lonely. I was bereaved
Right.
2.5 years ago.
Oh, right.
Not having someone to talk to hug, to share things with. The more elderly people particularly, it's part of life. I can promise you that it can be devastating.
How do you think we can combat it?
The answer to that, probably the key would be to be aware of people. To talk to someone in that situation who is lonely, you have to, it really requires a little effort, doesn't it? I think that's the key.
You just saw the website for that, the Campaign to End Loneliness that I mentioned a few minutes ago. That will be provided to you through this project, through these sessions. There'll be a list of references, but there'll also be a link for the Campaign to End Loneliness where you can find this film and many others, including, for example, there's a very poignant one with an older woman who lives alone, is really, really feeling very, very isolated. So some days she will just get on a bus and ride around London on a bus and just hoping that someone says hello to her. So this leads me to this next slide, which is the definition of what is loneliness. I think we all understand loneliness. We've all experienced. If you've lived any time at all on this earth, you will have experienced loneliness. The question here is the degree or the length. So what I'm talking about here, even though I don't say it every time, we're talking about chronic loneliness, something that doesn't end. I was lonely for a few days or a few hours or a few weeks, but this is something that goes on without end. The definition that I want to share here first comes from one of the first researchers. She was actually a psychiatrist as well, Dr. Fran Reichman, who observed loneliness in the patients that she served, that she took care of, psychiatric patients, and she was able to connect how that loneliness affected the quality of their lives in a very significant way. And so this quote is from Dr. Fran Reichman, and she said, "Loneliness is an excruciatingly painful emotion evoked by the realization of the lack of meaningful contact with others." That's her definition of loneliness. We know that loneliness is a feeling. A lot of the emotions that you cited were represented feelings. I'm feeling sad, I'm feeling depressed, I'm feeling despondent, I'm feeling empty. So a distressing feeling, so an emotional state of being alone or being separated from people that you love and care about. This is a definition that I've used for a long time because it makes the most sense to me. Loneliness can be understood as a difference between desired and actual contact with others. If you think about in your own life, some of you are introverts, some of you are extroverts, some of you are somewhere on the scale. I understand some of my family members are introverted extroverts or extrovert introverts. I forget how that goes, but we all fall somewhere on this continuum of how much social connection do we need in our lives on a regular basis. If you look at this definition, you think about it in your own lives, it's very individualistic. I'm a very gregarious social person. I draw energy when I'm with people. I need to have people in my life on a regular basis. This is perhaps a problem for me, but what I desire and what I actually get, if that distance is too great, that would represent loneliness. Not everyone needs to have a multitude of people in their lives on a daily basis. I was telling the team yesterday, I did a study years ago, a research study up in Gogebic County, way up in the UP bordering Wisconsin. And I learned that some of those older adults hadn't seen individuals for weeks, maybe 2-3 weeks at a time. And yet we can't necessarily conclude that they're lonely. That's perhaps an environment, a culture where they were raised. They're used to not going to the store every day, that sort of thing. So just think about in your own life, what do you actually desire in the way of social contact? And actually, how much contact do you actually have? And I want to just take a moment now and contrast this. We go from an emotional state to social isolation. So here we have the physical lack of social contacts in our lives and very few people to interact with on a regular basis. I want to come back to this point again, though, about the meaningfulness of this. To reduce the perception of social isolation, and also you could say loneliness, these relationships need to mean something to people. It needs to be someone who knows who I am, that knows that I'm more than I'm the resident in XYZ room, but who am I? What am I about? What do you know about me? What do you know about me pre-morbid? Before I was diagnosed with dementia, what do you know about my life? The things that were important to me. Now there's a relationship that's meaningful to me. We know that social isolation and loneliness are separate ideas. We also know they're very much related to each other. Even though people in Gogebic County in Michigan may not have been lonely, I'm at a higher risk for loneliness. But now I want to turn this to the world that you all operate in, long-term care. All of you are involved in some capacity, in some role with nursing home residents. If you think about your environment, if you live in a nursing home or you work in a nursing home, there are people everywhere. There are things going on all the time. There's a lot of stimuli. Sometimes it's good stimuli, sometimes it's less ideal stimuli. Call lights, med carts, staff, you got family coming in, lots of things going on, residents that need extra care, lots and lots of things going on. So I am, as a nursing home resident, I'm typically going to be surrounded by lots and lots of people. If you think about that environment for a minute, I'm going to ask if you'd be kind enough to write some thoughts in the chat box, please. How might long-term care residents be considered socially isolated? Or I might even add, what puts them at a higher risk for loneliness, even though they're not socially isolated? Would you write a few thoughts in the chat in your own facilities, what you've observed? I'm reading some of these. I know you can all see it as well, but just to share some of these, they may not know or like the people with whom they interact. Communication challenges, which we're going to talk about in a little bit. Not able to get out into the community. My dad was isolated for a bit before he could use a wheelchair. Then apparently that improved. He was able to move around more. They've experienced a lot of loss and they continue to lose friends. Beautiful. Other thoughts? A couple of you wrote about family members not visiting, not able to take them out. Family members live too far away. They're sort of in a difficult position of just waiting for people to come see them, to show up. A lot of dependency on others' actions to help lift them out of some of these feelings of isolation and loneliness. Loss of pet, family, friends, independence. All of these really serious challenges as we get older that put us at a high risk. Financial barriers with assistive technology. In the next session, I know we're going to talk a lot about, which happens in August, we're going to talk a lot about assistive technology and where that fits in with addressing loneliness. Thank you very much for sharing those. A whole host of reasons that suggest this population, the population with whom you work, those with whom you serve, would be considered at quite a high risk. Let me talk about some of the factors that actually increase our likelihood of feeling lonely. One is advanced age. And let me just say, a lot of these factors or variables or conditions, these overlap with each other. So for example, the first two, advanced age means you're probably going to be more likely to have lost a partner. So advanced age, we know that the oldest old are more likely to report feeling lonely compared to, say, the younger, older persons in their 60s. So advanced age is a risk. Loss of partner, some of you wrote that already in the chat. You said loss of a partner, either through death or divorce, very easily understood, put someone at a high risk for chronic loneliness. Gender. This one's interesting because we have many, many older men, high rates of loneliness among older men, and various serious outcomes going along with that. But older women are more likely to report that. Just as we know, research tells us that older women are more likely to seek help, to seek medical care, to seek therapy services when there's a mental health challenge. We're better at doing that than men, but a lot of concerns about men. Women are better at making friends. So that is a problem for older men. Sexual orientation, we have some evidence that individuals in the LGBTQ community are at risk for becoming lonely and isolated. That's particularly true in the long-term care facility, especially for those who haven't had support from their family or others, or perhaps haven't even come out yet. Problem for them with respect to loneliness. Some additional factors affecting the risk level is geography. Some of you wrote that families don't come often, or perhaps they don't come at all. Part of that is distance. We live in quite a relatively mobile society. Our son lives in Bend, Oregon, and our daughter lives in Chicago. They don't live near me. And so sometimes that's a problem when family members are at a distance and cannot travel often to visit. That can increase loneliness. Spirituality can be an effective intervention for helping people in later life cope with loneliness. However, we have to think about that in the long-term care setting. To what degree is one's faith going to be addressed, represented, attended to? I know years ago I had done a study on loneliness among ethnic elders. And I remember a gentleman, he was from Vietnam. He was Buddhist and he was extremely lonely. We had a hard time understanding this well because he didn't speak English. But it was a challenge for him because there was not anyone there coming to help with support his Buddhist faith. So spirituality can be a plus addressing loneliness. It can be something to alleviate loneliness, but we have to make sure that we're looking at all the faiths, not just the more major dominant faiths in our country. Speaking of ethnic minorities, I truly believe that ethnic minority elders in the facilities, even though they are small in number, may be among the loneliest. We know that particularly with dementia, it's called bilingual aphasia, individuals will often, maybe some of you have seen this in your facilities, they'll resort to their primary language as the dementia progresses. And so it may be that I was able to communicate in English. As the dementia progresses, I will often resort to my primary language. So now I only speak Korean. There's no one in the facility for me to communicate with. So I think ethnic minority elders are considered a very high risk related to loneliness. And then some of the issues that a lot of you already pointed out in the chat relates to poor health. How does our health intersect with the feelings of loneliness? Well, there's certainly memory loss, our ability to walk independently, or as one person put in the chat, now the person has a wheelchair, that person can move in ways that and connect with people in ways that might not have been possible in the past. And then sensory issues, I think a few of you put this, I'm looking a few of these ideas here. Not being able to hear or see well is very isolating, very difficult for me to connect with other people when I don't really understand what's going on or can't enjoy things that others can see who might have better vision. So poor health is absolutely a risk factor. I want to talk about this idea about what does loneliness look like from a prevalence standpoint in nursing homes, and also should we be concerned? So we've talked about what loneliness is. We've talked about the risk factors. And now I want to turn to this really second objective to say, is this, okay, there's a few lonely people, or is it more than that? And to what degree should all of us be concerned, if not alarmed, if you will, about this topic? The first thing that I want to tell you is that we don't have great data on this, okay? We know that, for example, the AARP, the American Association of Retired Persons, did a very large national study of loneliness in the population, and they did it for persons over age 45. So not necessarily just older people, but middle age and up. And they estimated that approximately 1/3, 35% of the US population viewed themselves as chronically lonely. We have evidence from research that college students, the population that I work with on a daily basis, college students can be seen as very, very lonely. So those of us who work in this field look at this and see it as an epidemic. So if I said 1/3 of the population had cancer, or 1/3 of the population had whatever condition, we would see that as a serious epidemic. What we need to do is start talking about loneliness and addressing how serious it is. But I want to talk about what the challenges are for us to come up with a number in the nursing home world. First of all, it has not been an area of population where we have a lot of prevalence data. Little is known. We know that the risk factors are high. We just went through the risk factors. We know that they check a lot of those boxes: loss of partner, advanced age, memory loss, et cetera, et cetera. But we don't have a lot of great prevalence data, epidemiological data to say, here's what the number is. However, we think that the risk is probably double to older persons living in the community. It could be as high, some estimates, as high as 42%. So that's approaching half. Half of the residents that you serve would be possibly considered as chronically lonely, compared to about half that in the community. But here's some of the challenge that I'm sure all of you have already thought about in this context. And I want to say, draw attention to, which I just blew past in the chat, and this will be sent to you as well. Some of you are thinking, okay, these estimates for loneliness, how do we know these numbers? I can tell you, we have assessment tools addressed to evaluate loneliness. 3 of them are in the chat: the UCLA loneliness scale, the De Jong-Gierfeld scale from the Netherlands. All of these have been translated into English. And then there's ones that are used just in 3 items, a 3-item scale that you could, with 3 items, you could get a sense of loneliness in your facility. So there's multiple ways for us to actually estimate loneliness in any context. But let's talk about some of the reasons why this is so difficult. What are the special challenges for you in the nursing home setting? First of all, I want to talk about loneliness is a highly stigmatized condition. There is something about our society, just like mental health, like depression. If I broke my wrist, I'm happy to tell you, gosh, I broke my wrist last week. I'm going to be less likely to tell you, gosh, I'm really struggling with depression. If I said that to you today, your image of me has changed. We have not evolved to the point where we can talk about mental health freely in a way that doesn't feel so stigmatized. And so loneliness is the same thing. If I had all of us in a room today and I said, everybody dig down to your deepest feelings right now, and please raise your hand if you consider yourself lonely. That's a hard thing to do. We don't want to share that information. I was saying yesterday, I think sometimes we see it perhaps as a moral failing of who we are as human beings, that we should share that loneliness is something going on in our lives. And I think that's true for nursing home residents too. We don't want people to feel sorry for us. I don't want to burden my family members. So the last thing I want to do is make my daughter feel more upset about me being in this facility. The stigmatized aspect of this is difficult. And then the last two bullets here have to do with dementia, which I think is something we cannot bypass. Almost all the studies that have done on loneliness in a nursing home setting have been done for people who are cognitively intact, not for people with memory loss. There's a few I'm going to cite in just a moment, but we don't have good data, extensive data on to what degree is loneliness widespread in people with memory loss. And then if you take into account approximately 70% of all nursing home residents have some type of dementia, Alzheimer's, Lewy body, frontotemporal, whatever it might be. So you've got the bulk of people in your facilities who have some kind of have some sort of a dementing illness, and yet we don't have good data to support where they are with respect to loneliness. And here's one of the few studies, though, that I can share with you, the work of Dr. Cohen Mansfield. If any of you have done any reading related to anxiety, you would recognize her name. She's got a couple tools, the Cohen Mansfield Anxiety Scale, very well-known researcher. She had one of the few studies of loneliness among nursing home residents, and she estimated that approximately 70% of them reporting feelings of loneliness. So that's why a lot of us would say this is an epidemic. This is not, oh, there's a few people that really struggle with this. This is the vast majority of your residents, potentially those with dementia, having a sense of loneliness. And then I want to say this research pre-pandemic, the work of these two researchers cited that many residents with dementia believe that their family member had not visited them even when they had. And I'm sure some of you have experienced that. My daughter hasn't come, my son hasn't come, I haven't seen so-and-so for so long, and I feel really sad and lonely, even though they may not be able to verbalize that. And yet that family may have very well have visited. So that's a problem. And I know those of you who have been working long-term care through the pandemic could do your own PowerPoint presentation about loneliness and what this picture looked like for people during that very difficult time period. I'm hoping I'm painting a picture why we should all be concerned about this, if not alarmed. And like I said, the U.S. Surgeon General has now recognized this as something that we should care about. But I want to share specific outcomes of loneliness to further illustrate why this is such an important topic. First of all, these are all independent. These are all various research studies, and there will be there's a reference list available to you that if any of these you'd like to dive in further. But here's just a few examples. And honestly, I could have given you 10 more slides about all the areas that loneliness affects our health. So for example, we see this as a risk factor for coronary heart disease and stroke, hypertension, increased inflammation of the body. So there's a marker called C-reactive protein. It's a biomarker in the body that suggests the body is under stress. We know that's not a good thing for our bodies to be under stress for long periods of time. We know that individuals who are lonely have higher rates of C-reactive protein in their bloodstream. We know that it can affect one's functional status, including climbing a flight of stairs. Mental health, you can probably very easily imagine. We have evidence controlling for other factors such as age, other comorbid conditions. We see that loneliness can put individuals at a greater risk for developing memory loss and dementia. And I've thought about this finding a lot, and I can only conclude that it is and I have no definitive data to support this, but in my head, I've put this together as I have very little stimulation from other people. And so it's putting me at a greater risk for dementia. It's also this idea that loneliness, I'm going to push people away. It makes me more isolated. Please don't come in my room. I want to be alone. But maybe at the heart of this is I'm feeling lonely. People have not connected with me in a meaningful way. Pushing people away, Now I'm in an even more isolated environment. It puts us at a higher risk for depression. So depression and loneliness are very much correlated with each other. There are people, like I said, who are just lonely and maybe don't move into the criteria for depression, but they're they can be very much related to each other. Maybe loneliness is a precursor for depression, or maybe the other way around. People are depressed and then they become lonely. This is, by the way, a fantastic resource. The National Academies of Science, Engineering, Medicine, it used to be the Institute of Medicine, came out with a very extensive report in 2020 addressing loneliness in our population. And then, as you can probably imagine, loneliness is a risk factor, is predictive of suicide in older age. As I said earlier, older men in particular are at high risk for suicide when they've lost a partner. Sometimes their partner is the only confidant that they have. Women are much better at making friends, having a broader social network. So older men who are seen as lonely, we should be very, very concerned, very cognizant of their quality of life and suicide risk. And I want to put this slide out. Part of this is on the back of a study done in the Netherlands of people over age 85. And they saw when both of these conditions were present, the depression and the loneliness, so a person was assessed as being lonely, the person was also assessed as being depressed. Those two were enormously high risk factors for premature mortality. And as I've thought about that finding, I have this statement that I wanted to share with you. Depression and loneliness may result in resignation, leading to reduced self-care, or even in your context, resistance to care. So I've just essentially given up. I'm not really interested in what I look like, combing my hair, getting dressed, going out to meals today, participating in any activities, because I've just really given up. I don't feel like I'm connected to other people. That's a very, very serious condition for someone to be in. I've already put out a number of citations for research articles related to loneliness, and certainly there are many more that are available. But I want to share with you, this is probably the most famous slide for those of us who are involved and interested in research related to loneliness. This was conducted by a woman named Julia Holt Lundstad. She's a researcher at Brigham Young University out in Utah. I met her at one of the conferences on loneliness, actually in England, and she presented these findings were based on a meta-analysis. So I'm guessing some of you have heard of systematic reviews, where multiple research studies are brought together and the findings are compiled. This is the same idea, except it's not just the conclusions, but it's actually the data. So she put data in from multiple studies related to loneliness, and these are all odds ratio. They're risk factors of mortality. Okay, so what are the risk factors from having BMI of XYZ, or hypertension, or air pollution? So you can see there's various risk factors. Anything over 0 is you have an increased odds of dying, of mortality. Okay, so you don't have to read all these, but I want to point out to you, second and third bar, which are the longest bars, represent social isolation and loneliness. And so both of those increase the odds of mortality among individuals. And if you look at the other ones, I know some of the font is a little small in this from the article, but anyone who works in loneliness knows this sort of punchline, if you will, not to make light of it, but chronic loneliness increases our chance of dying, chances of mortality, even more than well-known factors such as obesity, which we know is a risk factor, and 15 cigarettes a day. And that's on here somewhere. I have to find it. You can see alcohol, you can see smoking. So it's even higher than the, I think, fifth one, smoking. So this speaks to the really significant nature of paying attention to loneliness. We have to move past the point of, I don't know what to do with it. Is kind of winding down these remarks. I'm hoping that you will at least give some thought to the following: that nursing home residents, the people that you serve every day, who report feeling emotionally lonely. This is an emotion. This is a painful, remember, an excruciatingly painful condition. They will die sooner than those who don't have such a condition in their lives. They will die prematurely, die before their time. And I would say, even if a resident, all the residents that you serve, some are able to, perhaps some of them are able to say, I feel lonely, I miss my daughter, I miss my partner, I miss my dog. Those who are able to verbalize loneliness, that's a serious piece of information that we're given. But even those who are not able to say that because of their memory loss, because the stigmatization, because they think that's a normal part of aging, even those individuals who are indeed lonely, we have to acknowledge that the quality of their lives is seriously, seriously and dangerously compromised. I want to say, I consider an assessment of loneliness in the same category as a vital sign. You take my blood pressure on a regular basis. I go to the doctor. The doctor asks me, are you taking your meds? Check your heart rate, et cetera, et cetera. All the things that we consider vital information, vital signs. I'm hoping that you'll all start to be thinking about this is a vital sign too. All the adverse outcomes that are related to loneliness, that we also consider loneliness, not something to turn away and say, there's nothing we can do about it. But first of all, try to start paying attention. What you heard from that short little video clip back in England was, if you remember, the older man said, the young man turned to him and he said, this is really hard and what can we do about it? And the first thing, if you remember him saying, is that be aware of what's going on. We can't afford to put our heads in the sand and say, oh, these poor lonely people, isn't that sad? We have to do better. All of us have to do better, in whatever context that might be within which we operate. So I'm hoping that you'll come back. And I know that Colleen will talk about this in a few minutes for the next session, where we can talk more specifically about things that we can all do, including in the nursing home environment. But I'm asking if you could give some thought to the following. What types of behaviors or comments have you noticed among residents suggesting that they actually are lacking meaningful social relationships, which are so important to the lives of older people and this picture of loneliness and feeling lonely in their daily lives? And then pay attention to what is the impact is that having? Are they not leaving their room? Are they not interested in participating with other residents or with staff? So just being aware and thinking about, have I really even talked to anybody about this? Using some of the assessments tools, if you're interested in that. As we wrap up, I wonder if anyone would be willing to write some things in the chat. If you'd be willing to just say, if you've noticed loneliness in your facilities, or if you had conversations with residents about loneliness. Here I have some comments coming in. I guess people have forgotten about me. Thank you, Amanda. Rhonda wrote, yes, we have had conversations. The challenging situations are those that are pushing people away. And I do hope some of you are able to come to the next session, because I want to talk about that family estrangement. Those put people at a really high risk for feeling lonely. Family relationships aren't easily replaced. Close friends aren't easily replaced. None of us can afford to get rid of friends in our life, as far as I'm concerned. Sleeping throughout the day, not eating well. Yeah, these are really, thank you very much for writing in for these comments. And these must be enormously difficult for you to hear, and feeling a bit powerless. I've had residents say that they are lonely and feel like they were just left at the facility. The family is too busy for them. And I'm sure as staff, when you hear those comments, those are painful for you to hear as well. I'm sure you're all empathic people, or you wouldn't be working in the field that you do. I had a resident beg me to stay and talk for a while because the CNAs were so rushed. And then there's issues related to the workforce and understaffing, and CNAs have to keep going with all the ADLs, and just sometimes we just want someone to talk to, maybe just about the weather, anything, just to make a human connection. Thank you very much, Whitney. Thanks. I appreciate this very much. And I thank you all for being here today. I'm grateful for you taking time to learn about loneliness. And I hope it will give you some thoughts about moving forward to perhaps be more mindful for the people that you serve every day. Thank you very much for your time.
Oh, goodness. Thank you, Dr. Mikas, for this powerful presentation. And thank all of you for joining us today. We hope you can join us again on August 8th when Dr. Mikas presents our last session, Effective Approaches for Reducing Loneliness in Nursing Homes. Thank you again, Dr. Mikas, and thank you for all that were here.